Welcome to the second lecture on pediatric lung diseases. In this lecture, I'll be focusing on chronic pulmonary diseases of childhood. These are the objectives that you should know for the upcoming exam. All of the information you need to know is within this lecture PowerPoint. There's some recommended reading if you have the additional time and interest. We'll start with talking about cystic fibrosis. There's a quote from German folklore in the Middle Ages. "Woe to that child which kissed on the forehead tastes salty. He is bewitched and will soon die." This refers to the saltiness of the sweat of children that have cystic fibrosis. This is a cartoon representing some of the problems in the treatment seen with cystic fibrosis. In 1938, at Columbia Hospital, a number of children presented with severe dehydration, but without vomiting or diarrhea. Several had been followed by GI clinic for failure to thrive and greasy stools. Many had noted to also be coughing. That was the initial recognition of the separate disease, cystic fibrosis. By 1946, a genetic nature was identified. Cystic fibrosis is the most common life-shortening recessive genetic disease in Caucasian individuals. It is transmitted in an autosomal recessive manner. It's due to mutations in the CF transmembrane conductance regulator, the CFTR protein. It encodes a regulated cell membrane chloride channel. It leads to defective transport of chloride across epithelial. Altered luminal fluid properties contribute to the pathogenesis in multiple organs. So we see it not only in the lungs, in the pancreas, but also in the GI tract and elsewhere. Here we can see a comparison between a normal CFTR channel that's moving chloride ions to the outside of the cell versus a mutant CFTR channel that is not moving those chloride ions, causing sticky mucus to build up on the outside of the cell. That's the primary problem in cystic fibrosis. It's that sticky mucus that builds up. The epidemiology. The incidence is about 1 in 2,000 to 1 in 4,000 live births. The carrier frequency is about 1 in 25 in Caucasian individuals. It occurs less frequently in Hispanic populations, much less frequently in African American and Black populations, although I have certainly cared for patients of both of those populations with cystic fibrosis, so it doesn't mean that it never happens. There are multiple types of mutations that can affect the CFTR, which reside on chromosome 7. So there are about 900 mutations across 4 different classes. Most common are class 2, which is a deletion of a phenylalanine at position 508. Counts for about 70% of the mutations in Caucasian individuals. The diagnosis, it's primarily clinical with laboratory testing for confirmation. Here in California, all newborns are screened for cystic fibrosis or could be screened for cystic fibrosis. Parents can opt out of it. We can also do sweat chloride testing. Ideally, that's done at a CF center or a children's hospital that deals with cystic fibrosis patients. And then there's also the nasal potential difference test that can be done. But let's talk about that clinical presentation. When do we worry about cystic fibrosis in one of our patients? The median survival time has increased over the past 60 years. So now the median survival age is about 35 to 40 years. If you look at that graphic up in the top corner, you can see the different treatment modalities that have been added in that have contributed to that increase in lifespan of patients with cystic fibrosis. The prognosis certainly worsens with increasing complications. Bilateral lung transplantation remains uncommon, but transplant complications are the second leading cause of death in cystic fibrosis. So bilateral lung transplantation still occurs quite frequently in patients with cystic fibrosis, and complications of those are the second leading cause of death. As we're focusing on the respiratory tract component of cystic fibrosis, we note that it's the primary cause of morbidity and mortality is the chronic endobronchial infection with progressive obstructive lung disease and bronchiectasis. The onset of pulmonary disease is variable. Most have signs as infants and toddlers, right? So that initial just coughing, the thick mucus, the difficulty clearing their secretions, those type of things. The leading hypothesis is that due to poor chloride transport into the bronchial lumen, lower airway secretions or thick, viscous, and low volume lead to reduced mucociliary clearance, which leads to a respiratory tract that is chronically infected, causing chronic inflammation and acute exacerbations, which leads to progressive destruction of the lower airways. So here we can once again see those viscous secretions leading to mucus plugging. As mucus is plugged in there, bacteria can get trapped in it. Bacteria isn't cleared the way it normally would be, so you get an increased risk of infections, increased incidence of infections, which causes further inflammation, further damage. Here we can see a lung biopsy of early cystic fibrosis lung disease with mucus plug within a small airway and normal lung parenchyma. That's in the histologic image. And then in the pathologic image B, we can see an excised lung that is showing severe bronchiectasis. So those dilated distal airways near the pleural surface with hemorrhagic mucus plugs. So you can actually see the blood that's been trapped in there along with all that mucus. Chronic respiratory symptoms are the most common presentation leading to the diagnosis of cystic fibrosis. Signs and symptoms of CF respiratory disease include a chronic cough with sputum production, right? So whenever we hear that a patient is coughing, one of our first questions is if it's productive or not. So sputum production is what we expect in cystic fibrosis. We may also hear wheezes or rales. The patient may exhibit increased work of breathing, and their chest x-ray will be abnormal, showing hyperinflation or atelectasis infiltrates bronchiectasis. And then the respiratory complications of cystic fibrosis include hemoptysis, pneumothorax, respiratory failure, right? Things due to that really chronic coughing, the really strong, forceful coughing, trying to clear, right? They're trying to clear their own airways of that thick mucus. It can be really difficult. Typical course is a progressive chronic respiratory illness with minor and major acute exacerbations. So slowly over time, they get worse and worse. A minor exacerbation is when you get an intercurrent viral illness, right? So a viral upper respiratory tract infection that may turn into or develop into bronchitis. You have that increased cough, mild increased sputum with a normal activity and appetite, normal pulmonary function tests. We manage them as outpatient, as we would with almost anybody, but maybe they have an increased requirement for more breathing treatments to assist with the mucociliary clearance, maybe some oxygen. And then this is in contrast to a major exacerbation, also known as a pulmonary exacerbation of cystic fibrosis. That's when the cough has become severe. There's marked sputum production. We can see changes on the chest x-ray, changes in the pulmonary function tests, diminished activity and appetite. And these patients need to be admitted and managed as inpatient, usually with really good nutritional support, IV fluids, along with all of the support for their pulmonary function. Criteria to consider pulmonary exacerbation. You need to have 3 of the 11 in order to call it a pulmonary exacerbation. So that's that major exacerbation we were just talking about. Having an FEV1 decreased more than 10% from baseline, increased cough, increase or change in sputum production, fever, more than 5% weight loss, reduced exercise tolerance, decreased oxygen saturation, having new findings on chest x-ray, increased respiratory rate or work of breathing, school or work absenteeism in the past week, or new findings on chest physical examination. So having at least 3 of those puts it from a minor exacerbation to a major exacerbation, needing inpatient treatment. Common pathogens in the respiratory tract of patients that have cystic fibrosis are Staph aureus, non-typable Haemophilus influenza, and then gram-negative rods, in particular Pseudomonas aeruginosa. I want you to really associate Pseudomonas with cystic fibrosis. I want you to have that link in your head, especially for board exams, but for real life as well. Pseudomonas isn't an incredibly common organism in healthy individuals. Patients that have cystic fibrosis, they tend to get recurrent pseudomonal infections, and Pseudomonas is difficult to treat with our current antibiotics. We also see the Burkholderia, Kaposia, Klebsiella pneumoniae. Data from respiratory tract cultures help to guide our therapy, right? But we don't get those cultures back for about 48 to 72 hours. So we often go based on previous culture results to start some initial empiric therapy, and then as soon as we get the current sputum culture results back, we'll tailor the therapy to the specific organism that's causing their current exacerbation. Staph aureus, non-typable H. flu, and Pseudomonas are the ones I want you to really highlight for this particular disease entity. How do we treat a pulmonary exacerbation? At least 10 to 21 days of antibiotics, and usually it's a combination of an aminoglycoside as well as a beta-lactam for pseudomonal coverage. We also do something called aggressive chest physiotherapy. We want to try to help them release those secretions, right? Those mucus plugs. Those plugs not only plug up their airways so that they can't oxygenate, but they also serve as areas where the bacteria and pathogens get trapped, and so it's very difficult to get rid of them without clearing those mucus plugs. You can see here I have a picture of somebody, a chest physiotherapist, basically hitting the child's back with a cupped hand. That can help them with some of that clearing those mucus plugs, something that parents are taught. We also do something similar with a vest. There are particular vests that kind of jostle the patient's chest and can help to dislodge those mucus plugs. Then giving the patient bronchodilators can help open up their airways so that they can cough out some of that mucus. We also do serial chest examinations, right? So really relying on our physical examination skills, relying on us to make sure that we are documenting clearly so that we can tell day to day how things are progressing. Also serial chest x-rays, pulmonary function tests, and surveillance cultures. And we treat until we observe a plateau in respiratory function improvement. Every time the patient has a pulmonary exacerbation, they may not go back to their old baseline. They may establish a new baseline where they're a little bit worse off with functioning. This is a chronic progressive disease. The maintenance therapy of pulmonary disease includes airway clearance at least 3 times a day, so bronchodilators and mucolytics, so trying to find ways that we can help move that mucus along so that pathogens don't get trapped in it. And then intermittent oral antibiotics. You may alternate once a month, inhaled tobramycin, so things that can hopefully help to prevent any pulmonary exacerbations from infections. And then we do frequent follow-up with routine chest examinations, chest x-rays, and PFTs, so we can try to capture those minor exacerbations before they become major exacerbations. Moving on to what happens in the GI tract of patients with cystic fibrosis. Pancreatic function is divided into endocrine and exocrine functions. Exocrine pancreatic insufficiency occurs in most patients with cystic fibrosis. It's the main source of digestive enzymes for fat, protein, and carbohydrate digestion, right? So our exocrine pancreas releases these enzymes that help to break down the fat, protein, and carbs in our diet. Right, so secreting the trypsinogen, chymotrypsinogen, pancreatic lipase, and pancreatic amylase. And we see that that is greatly decreased in patients that have cystic fibrosis. The extent of GI tract disease in patients with cystic fibrosis highly correlates to their genotype. It's based on their presence or absence of steatorrhea, which is fat in the stool. So if you have fat in the stool, fat will actually float on the surface. So one way to ask a patient if their stool is fatty is to ask if their stool is floating. It may also have a greasy appearance, may even see some grease kind of floating on the top of the surface of the water. The pathogenesis behind this is poor chloride transport into the pancreatic duct lumen, which leads to thickened exocrine secretions, leading to plugging and poor transport to the duodenum, leading to less exposure to digestive enzymes. And so then you poorly absorb those nutrients, right? If we can't break down our fats because we're missing those pancreatic enzymes, then our fats just get secreted into our stool, which is why we have greasy, fatty stools. But it also means that we're not absorbing the critical components in fats that we need, like our fat-soluble vitamins. It leads to poor weight gain, undernutrition, diarrhea, and steatorrhea. This is a chart from Mosby showing the key features of GI disease in cystic fibrosis. I'll let you read through that on your own. You can see that meconium ileus, malabsorption, maldigestion, pancreatic insufficiency, hepatic disease, all of those are some of the key features. They all have to do with those chloride channels not functioning and then what they cause in their particular organ. Management of GI disease in patients with cystic fibrosis is to optimize the pancreatic enzyme supplementation. So it means that these patients are actually taking pancreatic enzymes every single time they eat, so with every meal, so that they can break down their fats as they need to. We're also supplementing them with fat-soluble vitamins that they may not be absorbing well enough on their own. As a reminder, those fat-soluble vitamins are vitamins A, D, E, and K. We may need to give them laxatives to maintain soft stools, because if you can imagine that thickened mucus plug that happens in their lungs, that can happen in the GI tract as well. So things may not move as smoothly in the GI tract without some medication to help it. And then we're monitoring their growth really closely, their height, their weight, their BMI, looking for failure to thrive, looking for evidence of any malnutrition. Metabolic disease and cystic fibrosis, endocrine pancreatic function is also affected along with the exocrines, right? So the exocrine pancreatic function are like the release of those enzymes that help to break down our nutrients in our diet, but endocrine pancreatic function is also affected. We see CF-related diabetes. It's likely due to a combination of peripheral insulin resistance and reduced insulin production due to fibrosis of the pancreas. It increases as the patient ages, usually presents with fatigue, weight loss, and then the classic symptoms of diabetes, polydipsia and polyuria. These patients do have a low risk of diabetic ketoacidosis, which is not the case in patients with regular diabetes, especially type 1 diabetes. We manage them by monitoring their growth parameters, their height, weight, BMI, and then also checking their glucose and hemoglobin A1C levels. And they may need insulin, right? So unlike type 2 diabetics that may be able to get by with oral agents, patients with cystic fibrosis-related diabetes may need exogenous insulin, and we typically need to refer them to a specific cystic fibrosis dietitian, not just a regular dietitian that works with every patient with diabetes, because patients with cystic fibrosis have specific needs. Genitourinary disease and cystic fibrosis includes infertility. We see infertility much more common in male patients with cystic fibrosis in comparison to female, although it happens in both. There's abnormal sperm transportation and incompletely developed vas deferens in males. Females may have secondary amenorrhea, primarily due to malnutrition because they're not able to absorb things the way that they would if they didn't have the disease. We also see kidney stones, nephrolithiasis. This is unclear pathophysiology behind why we see this more commonly in patients with cystic fibrosis. In summary, cystic fibrosis is the most common life-shortening genetic disease in Caucasian individuals, but also occurs in other populations. There are multiple genetic mutations that can lead to similar pathophysiologic outcomes in cystic fibrosis. Careful prevention and timely management of acute exacerbations is necessary to reduce the risk of complications, especially time spent inpatient and worsening overall function. Cystic fibrosis management requires multimodal therapy, including pulmonary, GI, and nutrition. So we're doing a bunch of referrals for patients that have cystic fibrosis. We're going to move on to the second chronic lung disease, which is bronchopulmonary dysplasia. Bronchopulmonary dysplasia is essentially synonymous with chronic lung disease. The key criteria are persistent supplemental oxygen requirement with abnormal chest x-rays at 36 weeks post-conceptual age in infants who require positive pressure ventilation during the first 1 to 2 weeks of life. So what exactly does all of that mean? It means that we have an infant who continues to need oxygen, continues to have abnormal chest x-ray findings, and it's an infant who had required positive pressure ventilation early on, right, in their newborn period. We see high inspired oxygen content, a high FiO2, that is traumatic to neonatal pulmonary parenchyma. So when neonates are given really high concentrations of oxygen, this actually damages their lung tissue and it leads to chronic lung disease. It's exacerbated by high peak pressures from mechanical ventilation causing barotrauma. So not only is the high concentration of oxygen itself damaging the lung tissue, but the high pressure that we use when we mechanically ventilate somebody, when we put them on a ventilator, especially a neonate, causes further damage. The injury leads to inflammation and capillary leak, which leads to scarring, leading to increased airway resistance and reactivity, mucus production, cystic emphysema, and atelectasis. Bronchopulmonary disease exacerbation, typically a URI or other illness, leads to inflammation and edema of the airways, which then kind of starts the cycle all over again. They have further capillary leak with pulmonary edema and fluid overload. The incidence of bronchopulmonary disease is inversely related to the gestational age and birth weight. So the younger gestational age that a patient is born, so your highest risk if you're born at less than 28 weeks of gestational age, and if you have a very, very low birth weight. Probably because those infants are the ones that require mechanical ventilation, right? Their lungs are super immature. They're not ready to breathe on their own. So we need to intubate them and ventilate them. And then they're at risk of getting that lung damage, not only from the ventilation pressures, but also from that high oxygen concentration. Most of these patients have mild bronchopulmonary disease. Those with more severe disease are at higher risk for complications and need to be followed by a pulmonologist. Just like cystic fibrosis patients, we're not going to follow them as just general primary care providers. We're going to follow them along with other specialists like pulmonologists. The risk factors for bronchopulmonary disease include prematurity, as we talked about, with the greatest risk being born less than 28 weeks gestation. There is a genetic predisposition for it as well. Patent ductus arteriosus actually increases the risk, as does malnutrition. And then, as I mentioned, that positive pressure ventilation requirement. So if they needed to be mechanically ventilated, that's a huge risk. We do see patients with all of these symptoms: RDS, neonatal pneumonia, meconium aspiration syndrome, congenital diaphragmatic hernia, congenital heart disease, and other congenital abnormalities. We see these in full-term infants. Sometimes these conditions require that the patient be mechanically ventilated, and then that means a patient, even if they're full-term, can develop bronchopulmonary dysplasia as well. The central roles of the provider are to coordinate care among the multiple specialists, so the pulmonologist along with others, provide basic healthcare maintenance, and be familiar with baseline and identify when the kid is ill. We want to pick up when these children are having exacerbations or at risk for exacerbations so we can help keep them as healthy as possible. Diagnostic evaluation when the kids are well is really important so we can establish a baseline, so we know what the kids look like at baseline. A change in their baseline level of functioning may indicate a complication like fluid overload, pulmonary hypertension, or some sort of intercurrent respiratory infection. There are a variety of conditions that are related to the degree of BPD and prematurity. Management considerations. We want to make sure that they have a safe home with adequate space, utilities, phone access, transportation. These are patients who I often write letters for the parents to PG&E to make sure that they can maintain electricity in their homes, even if parents aren't able to pay their bills. They'll need supplemental oxygen if they can't keep their O2 sats up above 92%. And so parents will need to be taught about how to have home oxygen. They will need RSV immunoprophylaxis. So we already talked about palivizumab in one of the other lectures, that monoclonal antibody that we use for that. We want to manage and prevent reflux, because reflux, if it gets severe enough, can actually go into the airways. You can have microaspirations of your reflux, and that can damage airways. We want to do whatever we can to protect these patients' already damaged lungs. And then we want to make sure that we're doing a really good developmental surveillance, especially those patients that are born extremely premature. They're at risk of having all kinds of developmental delays. So the earlier and quicker we can get them into early intervention services, the better outcomes they have. So that means making sure we refer them to physical therapy, occupational therapy, speech therapy, and so forth. Specific treatment options for BPD include bronchodilators like albuterol. We may use inhaled corticosteroids to help decrease the inflammation. Diuretics, right, especially if we're worried about pulmonary hypertension or the stress on the heart. And then reflux medications. We want to try to prevent reflux at all costs. So things like ranitidine, omeprazole, metoclopramide. And finally, in summary, BPD is an iatrogenic complication of the management of some newborn diseases, right? So we actually cause BPD by giving oxygen at too high a concentration or by mechanically ventilating those lungs. It helps keep them alive in that period, but it also causes this chronic disease. It also requires careful preventative therapy and timely management with primary care providers coordinating care across multiple subspecialty services, just like with cystic fibrosis. These are my references. If anybody has any questions, you know how to contact me. Thank you so much. Have a wonderful day.